Okay. And so I think it would be really great if we just kind of go around my virtual room here and get everyone to introduce themselves. So I'll just do a roll call for those of you who show up in my box. So Hussein, can you go ahead and start?
Yes, absolutely. You guys can hear me okay? All right, perfect. My name is Hussein Bilal. I am a physician assistant. I work for the Department of Internal Medicine at the University of New Mexico Hospital Medicine. And I am the subcommittee chair for the Subcommittee for Health. Nice to meet you guys.
Anne?
Hi, I'm Ann Schultz, and I'm an intern at Cerna Solutions with Brian Cerna. I'm in my second year of classes at New Mexico Highlands for my master's in social work.
Darshan?
Hello, my name is Darshan Patel. I'm a third-year family medicine resident at University of New Mexico. I'm also one of the organizers in an interdisciplinary group for White Coats for Black and Indigenous Lives, housed primarily at UNM.
Jane?
I've done mute. I'm Jane Wishner. I'm the Governor's Health Policy Advisor.
Kaylee?
Hi, everyone. I'm Kaylee Salazar. I'm with the Indian Affairs Department, and I'm the support staff for the Health Subcommittee. Thanks.
Anjali?
Hi, everyone. Thanks to our guests for joining today. I'm Anjali Taneja. I'm a family physician and the executive director of Casa de Salud, a nonprofit integrative primary care clinic for marginalized populations in Albuquerque. And I also work in an emergency room on the Navajo Nation, and formerly also was a medical director for the jail methadone program at MDC in Bernalillo County. So come with a couple different perspectives.
Margaret?
I'm Margaret Montoya. I'm retired from the law school. I was a professor for 30 years, but I've been in health sciences for the last 15. I'm a critical race theory scholar.
Great. And Neal and Bryce, I'll let you decide how you introduce yourselves, if you want to start your presentation or however, but we will turn it over to you.
Bryce, you want to go first?
Sure. I'm Bryce Pittenger, and I'm in a very new position for me, full-time CEO of the Behavioral Health Collaborative, and I can describe a little bit about what that is later. I formerly, a couple weeks before this, was with CYFD as the Director of Behavioral Health for almost 7 years. And then before that, I was community mental health. I was clinical director at a place called Holadas in Albuquerque, worked at Allface, was in private practice. So I come from the clinical side as well as the sort of program and policy and now state side. So it's a pleasure to be here, and thanks for letting us join you.
So good afternoon, and I'm Dr. Neal Bowen. I'm the director of the Behavioral Services Division within the Human Services Department. And I've been in this position about 11 months now. Prior to that, I spent 14 and a half years as the Chief Mental Health Officer at Hidalgo Medical Services in the southwest corner of the state. And prior to that, I was faculty at a university in Washington State that was training counselors and community counselors and school psychologists, that sort of thing. And my specialty there was twofold. It was trauma because of what I did before I became a psychologist, and cultural competence, again, because of what I did before I became a psychologist. So I'd like to start with just a few reflections about how I approached this job based on where I came from in the southwest corner. Even before I thought about accepting this position, I often would talk about that there were three main issues with the workforce in New Mexico. First was in large part because of what happened in 2013 that I hope you're all already aware of. And if you're not, let's talk about it. But because of that, we just didn't numerically have enough behavioral health providers in the state. And part of what we ran into with that is that there are actually national standards for psychiatrists, but not for all the other behavioral health professions. And that's a problem with understanding what is sufficiency and what's not. And we're working a little bit on that. But so other than not having enough behavioral health providers, the second problem was the behavioral health workforce didn't or doesn't look like New Mexico. And that's a problem because people should be able to obtain services and feel that going in that they're going to be understood and valued for whoever they feel themselves to be, how they self-identify. And then the third problem was that the workforce is despite having a lot of universities preparing people for behavioral health professions in New Mexico relative to the size of the state, as someone who is hiring people at Hidalgo Medical Services to be professionals, it was amazing to me how much retraining we had to do to have people to be ready to practice in this time period. So I sometimes would joke that it felt like they were very well prepared to practice in the 1980s, but not so much for practicing in the 21st century. And so I'm going to address all three of those things and things that have been done by BHSD to respond to those issues a little bit. But I want to start with something called the class standards that I'm sure you're all aware of. It's the cultural and linguistically appropriate services standards, which are, as I understand it and understood it from the other position, are actually requirements of people receiving federal dollars to provide services. What I observed was it was very difficult to convince administrators that was a requirement. And so the implementation of class standards I found to be challenging, both because of the preparation of the providers and because of the lack of incentives to agencies to actually do that. So they were seen as at least in my experience, as an add-on requirement that was not funded in many cases, and so not sufficiently responded to. One thing I'm going to tell a little story at the moment, and I want to preface it. I'm multilingual. I speak a number of different languages. One of them is Spanish. I'm actually certified as a bilingual therapist by the state of Washington, because that's where I was before I came to New Mexico. There is no such certification in New Mexico, and there probably should be. That's one of the things that I would advocate for. And before I went to Washington, and I did my doctorate in the state of Texas, and one of the projects I did while I was doing my doctorate was I created a mental health clinic for refugees and asylum seekers. And because of that work, was recruited by the Texas Department of Health to help establish standards for the profession of mental health interpreters. And that just made sense to me, because when you use interpreters of convenience, there are very frequent mistakes made. And I can tell some pretty hair-raising stories from my own experience of that. And again, in New Mexico, there are no standards. There's not a profession of mental health interpreter. And so that's something else that I would want to pay attention to, because as I said before, people should be able to access services, comfortable that they're going to be accepted, and they ought to be able to access those services in the language they're most familiar with and most comfortable in, or at the very least, if they're one of the languages which is not well represented in the state, to be able to get those services with people who understand how to work with people who speak different languages. And so developing a profession of mental health interpreters, I think would take us a long way to actually implementing the class standards. In terms of what we've done to try to, since I've been here, and some things were already existing at BHSD, I want to point out that the COVID crisis has actually helped in some ways to bring to light the importance of modifying the way that we provide services. I also sit with something called the ESF6. It's a part of the Emergency Operations Center, which responds to crises and is managing the state's response to COVID with regards to food, shelter, and behavioral health services. And so as part of that, we've set up a number of different kinds of shelters, non-congregate shelters for people who need safe housing because of their COVID status or because of COVID status issues that they're facing. And as most of you will certainly know, the northwest corner of the state was the first that was very dramatically impacted by the COVID crisis. And so a large portion of the people that we were providing services to were from our Native American neighbors. And because we realized almost immediately that putting people in non-congregate care made perfect sense in terms of keeping them and the community safe from transmission of the virus, but it also increases the risk of behavioral health negative consequences. Isolation is not good for behavioral health, for your mental well-being. And so we created a system of connecting people who were offered that non-congregate care to also be connected to certified peer support specialists. And then very quickly from that, we realized that we needed to connect those certified peer support specialists to additional services. And so we mobilized Kiowa Behavioral Health Services, which is a Native American at the Santo Domingo Pueblo, and First Nations from Albuquerque to be able to connect them via telehealth to people who identified as Native American and were in the non-congregate care in order to provide culturally appropriate services to them. Frankly, that has not been used as frequently as we hoped it would be, but it's there and it has provided services to a number of different families. Another thing we do is because when I talked about the profession not being numerically insufficient and not looking like the communities in New Mexico, one of the things I was thrilled to find already at BHSD when I got here is that we support a pipeline project through the National Latino Behavioral Health Association, where we fund 10 scholarships annually for Latino or Latinx individuals who are in graduate school for one of the behavioral health professions. And in fact, they just had their ceremony last week. I was honored to be able to present one of the awards to one of them, one of the inspiring students from NMSU who receives that. And we're actually doubling the contribution from BHSD to the NLBHA to be able to double the number of the amount of support that they provide to people doing that. In addition, we've been working on there's a project to try to resolve or try to respond to that crisis of being well prepared to practice now rather than in the past. We've been implementing a project called Integrated Case Conceptualization, which is connected to a quality evaluation program called Quality Service Review. And we've had very good success just of late in connecting it, especially to Highlands, the School of Social Work. So I was glad to see a student from Highlands here, and to NMSU's School of Social Work, integrating it into their curriculum in order to help prepare people to understand both the cultural competence piece and the importance of integrated care of behavioral and primary care. If I can share screen, I just want to show you something. The Healthcare Workforce Committee at UNM just this week published their findings for this year, and I just wanted to show you the one aspect of the ethnic breakdown of the behavioral health workforce. So it's just these two tables that I want to show you, and it's as the federal government has done, it's broken out into ethnicity and Hispanic or Latino separately. So you can see across the top is the New Mexico population with percentages, and then in both, and then broken out by prescribers of behavioral health services, and then independently licensed providers, and then non-independently licensed providers, which tend to be early career professionals, and then substance use professionals. And I'll reiterate that for those last three, the independently licensed, the non-independently licensed, and for substance use professionals, there are no national standards for workforce adequacy. So it's one of the things we're trying to figure out here, what would indicate adequacy. One of the things, as I pointed out, is it certainly the profession should look like New Mexico. And you can see that for prescribers and for independently licensed folks, it really doesn't. It really does not look like the state at all. For any of these, I won't go through all the numbers here, but some piece of good news is that for the non-independently licensed professionals, if you look down here at the Hispanic or Latino as opposed to non-Hispanic or Latino, that makes up about 49% of the state population according to this way. And the non-independently licensed is almost 51% of the non-independently, it makes up, Hispanic providers make up about 51% of the non-independently licensed individuals. So that's kind of good news. One of the things I want to pay attention to and that we're working with UNM on is trying to make sure that their experience of receiving clinical supervision doesn't drive them out of the profession. And the reason I say that, and I say it that way, is because if you look at their independently licensed people, those are going to be their clinical supervisors right now. And that does not reflect the population of New Mexico the same way that the non-independently licensed do. And what that tells me is we've been making inroads in helping with the pipeline of providers being more diverse, looking more like the state, and that's a good thing. And they're coming into the profession now. One of my areas of research in Washington was looking at the people who had received training in cultural competence and were graduating prepared to practice in culturally responsive ways, and looking at their experience as early career professionals. And they were being supervised by people who had none of that training in their own training. And so unfortunately, the findings of that research was that they were getting the message from their clinical supervisors that was optional and was not valued and was not something which was of particular importance in the way that they practiced their career. So it was, we were training people, but it wasn't percolating into the profession as a whole, unfortunately. And then I left there and came to New Mexico for other reasons. So I don't know what's happened since that time. Hopefully we have more supervisors now who have been trained in clinical competence, but this looks to me like we could be setting up early career professionals for similar experience. So that's something that we have a clinical supervision learning community right now, which is pointing out that clinical supervision is a critical part of the quality of any workforce. And so we're trying to make sure that group is imbued with the understanding of the importance of the workforce looking and speaking like the community that they're serving. So I think with that, I would stop. I think I've probably said enough for the moment and be ready to take questions.
Bryce, did you want to give an overview of the Behavioral Health Collaborative?
Sure. Yes, because I know that there were some specific questions, I think more for Neal about RISE and LEAD. And those are kind of two sweet spots that are happening in our state. So yeah, the Behavioral Health Collaborative was created in statute in 2004. And the HSD Cabinet Secretary at the time was Pam Hyde. And the idea behind the collaborative was really to be able to pull together behavioral health statewide, utilizing 15 executive member agencies, including like Jane Wishner as the Senior Policy Health Advisor sits on the collaborative, Mariana Padilla as the Director of the Children's Cabinet. And so with that, at the state level, pulling together what are all departments doing related to behavioral health? So for purposes of this conversation that's already been started by Neal, how is higher ed, helping track and adjust what's needed in the field? What is Department of Health doing with epidemiology and prevention? How do we fold in what we're learning from Department of Health into our strategic planning at CYFD in terms of looking at what's needed, best practice for children and families and youth, and same with HSD. So the idea is it's sort of excellent and novel in terms of what other states have, and a huge opportunity. The other piece of that is at aligning at the executive level is great, both in a budgetary perspective. How are we spending our money? How can we leverage each other's initiatives? How can we all move in the same direction? There's also the people that we serve, and that's the Behavioral Health Planning Council. So there are the Behavioral Health Planning Council are folks basically with lived experience, and their role in the statute is to advise us all on the direction of the field, what's needed, what some of the concerns are. There are 3 subcommittees. One is the child and adolescent. The other is it's like a medicated adult subcommittee. I think I'm saying that right, Neal. And then the third is the Native American subcommittee. That actually, they call it the NASC, is the strongest of all subcommittees. And the Indian Affairs Department is the only state government executive department that sits both as a voting member of the collaborative and as part of the head of a Behavioral Health Planning Council subcommittee. And then the third part of that, the health councils fit in, that DOH manages, just to inform at the local level what's happening and to have some feedback loops to the state. But there was local collaboratives. So of the sort of 13 areas, there were local collaboratives. And when I was at Hogares, that was one of my roles, is to go and attend these meetings and listen and be part of it. Some of that shifted in the last administration and was defunded and changed. And so that particular local feedback loop is something that this administration is exploring. How do we do that in the best way possible? Because getting our things together at the executive level is great and much needed, but unless there's these loops to the folks that we serve and to the local communities, we still won't be necessarily getting it right because of the differing needs. So that's basically the idea of the Behavioral Health Collaborative. Our governor has set 4 priority areas for us to work within a framework with. And those priority areas are some of what Neal said. So expanding and improving workforce is goal number 1, and HSD is kind of the lead on that, although you can tell that all member agencies have skin in that game in terms of identifying and developing workforce. The use of peers, and that came from the Recovery and Resiliency Movement, is really sort of one of the forerunners of that particular effort right now. As what Neal described, what we're learning during the pandemic is that the people that, sometimes having a counselor, and I'll use myself as an example, that 70% or so of independently licensed counselors that are white, female, and over the age of 50. Sometimes not the best sort of mix to be able to connect with people that are in a very difficult time, in a vulnerable situation, feel exposed. And so our experience with peers, I think, especially during the pandemic, has really illustrated that point, that we need to continue to enhance our workforce there and integrate that into primary care. So think about that. Like, what would that be like to have a peer with lived experience to be able to talk to folks and be able to not be a counselor, but be able to identify, maybe here's what you could do. This is what I lived through. This is what you can do here. and also then be the gatekeeper to connect with the team for potentially more needed services. So that's the first priority area. The second priority area is expanding community-based services for children and families. And I will say, I am not from New Mexico. I've lived here 28 years. I feel like I'm from here. I don't ever want to leave here. But I will say that we've been through the ringer here as providers. And it was a really difficult time to see, you know, everything moving in a direction in 2013, and then have that. I was clinical director at one of the 15 agencies that got closed down. Unemployment for the first time in my life, you know, for a couple of months until I came to work with the state. And so for me, on a personal, professional level, rebuilding community-based services is not just taking it back to where it was before, but re-envisioning how can we keep kids in our communities? How can we keep kids with their families by meeting their needs? and by meeting their needs also implies that there's, you know, a very individualized strengths and needs assessment to be able to say, I don't, you know, put my, as Amy says, my lived experience and my culture and my identity is one spoke on the wheel. It's not the center of the wheel. It's just one spoke on the wheel. How do we, that's what a good system does. It puts aside bias and looks at the individualized needs of the kids and families and looks through a lens that does not, see a problem where there's not a problem. You know, the example of folks sleeping intergenerationally in a hogan and protective services coming in and said the kid needs their own room and their own cot or their own whatever it is. So the idea of rebuilding community-based services is huge for me. It's really where my heart is. And so that's goal number 2, and that's CYFD. The third goal, and when I say CYFD, sort of a lead, everybody's involved. The third goal is people that are living with substance use disorder. I mean, as you guys know, we're #1 in the nation for alcohol-related death and disease. You know, we've done a good job with the, sort of consolidated and directed and collaborative effort with the opioid use disorder, although we've got some, ways to go there. But, this is an issue in New Mexico. How do we do best practice? And I know some of your questions were around medication-assisted treatment and RISE and LEAD, and I think Neal would be the best person to address that. The fourth area is people involved in the criminal justice system. How do we do a better job about, both diverting, and we do a lot of that at CYFD. I worked with juvenile justice for about 3 years before behavioral health, do a huge amount. And I know that was one of your questions about what's being done to divert youth from the criminal justice system. We have 21 continuum boards, juvenile justice continuum boards that are sites all over the state that we pass through federal and state match dollars to do diversion. We're moving to more of an evidence-based practice model where if you want to do that, you're going to have to play in the sandbox and do something that really works. So the Girls Circle and the Boys Council are some examples of that. So if a child gets a petition, a referral, and per the Children's Code, the first 3 misdemeanors in a 2-year period, we just divert. That's what we do as a Juvenile Detention Alternatives Initiative state. So we may say, we want you to go to, Outcomes Inc. and do Girls Circle or Boys Council, and then they do that and we close the referral and it's done. So the idea is being able to identify needs and resources for children and families up front before or when they touch our system, and not get them deeper into our system just so they can get some of those needs met, if that makes sense. And so I'll just close by saying, in the children's world, one of the things that I think that we have learned, so much in trying to bring things above and beyond to where they were is that, because of who we are as a state, super rich in culture and tradition and beauty, also struggle a lot with some of those social determinants of health, access to healthcare, poverty, the systemic racism, some of those pieces that really put a heavy burden on kids and families to succeed at education, at anything in some ways. And so if we've learned nothing, it's that in order to really understand, we have to be holistic. We have to look at the whole picture. And SAMHSA does this great 8 domains of wellness, which includes, sort of work and spiritual life and social, emotional, and that really, all of those things align for us in our own lives if we're in a good space. And if a couple of those are out of alignment, there's no talk therapy that's going to get me out of that space, right? And so it's really being able to look at not just a cookie cutter approach, let's get this kid in therapy or let's send this mom to therapy, but what are the holistic needs of the child and family? And then encompassing that, a trauma responsive approach, meaning that, to be trauma informed, which is where our whole field is going, thank God, finally, means, you understand how trauma impacts people. You try really hard as a system to prevent re-traumatization as people touch our system. And then you take care of your own, from vicarious or a secondary trauma or burnout or compassion fatigue, whatever you want to call it. Trauma competent is being able to sit in it with the families and with the kids with those behaviors and help shift. Trauma responsive is really about acting with the appropriate sense of urgency. And so that's where we are, I think, as a system, as we look at what are the individual, sort of programs and things that we want to spring up around the state. And I can answer any questions related to that if you have them. Overall, how are we collaborating as a system? And that collaboration and that sort of safety net that we build together for kids and families is how kids don't fall through. If we continue to compartmentalize it, if we continue to say, that's education's problem, that's Dr. Banal's problem because that's a health concern. If we're not, sort of looping and bringing it all together, then one, we're burning families out with way too many things to do and running around to all of these different places, to get their needs met. And two, we are not actually, sort of building that sort of resiliency, helping build that resiliency and call that out in people that they can then stand up on their own with limited supports from us. So if there's specific questions about the children's system, either the behavioral health system, what exists, what doesn't exist, what's needed, child welfare or juvenile justice, I'm happy to answer. But I also know that this group had some interest in the adult system. And so I'll stop there and see what you guys, where you want to go.
Thanks, Bryce. Thanks, Neal. Very much appreciate that overview. And I guess we'll just kind of turn it over to you all for any questions that you have. And Hussein, I'm going to ask you to facilitate that and make sure that, that everyone gets a chance. So if you can look out for people's hands, and again, you can always use the raise your hand function. And then other questions can be put in the chat as well.
Fantastic. Thank you, Bryce. Thank you. Thank you, Neal. That was fantastic. Very informative. In fact, that answered a lot of the questions that we had. So I have my list right here in front of me, but I didn't want to hog it. If anyone else has questions that they would like to ask, either about any of the sort of list of questions we generated. Fair enough. So I guess my first question would be for Bryce, if that's okay. One of the things that I was concerned about was how children can get caught in the juvenile in the justice system from sort of school-based offenses, as well as how schools can disproportionately enforce discipline on minority students, specifically in the state, Native American, African American. I have some statistics, but they're pretty old, from 2010. But I was wondering if you guys had any initiatives that were looking specifically at that, as far as, maybe guiding school systems on how to either enforce discipline more evenly, more fairly, or having a way of sort of diverting that discipline from becoming sort of a stain on someone's record.
Yeah, it's an excellent question. We call that the school to prison pipeline. That kids will get in trouble in school and then weirdly get kicked out of school, where that's exactly where they need to be to continue to be safe and move forward, end up in the juvenile justice system, and then from there. So one thing is that New Mexico, this is one area that I can say with no bureaucratic whateverness, that New Mexico does a really good job. And sometimes folks would criticize us on that we don't lock up kids as much as we should. But we've been a juvenile detention alternative initiative state, which is through the Annie E. Casey Foundation, for about 15 years now. And so, yes, there are platforms through both JDAI. We've got a team within juvenile justice that works on racial and ethnic disparity, and looks at all of those statistics in terms of who we're putting on formal probation, who we're committing to, for lack of a better word, a kid prison, who we're incarcerating in jails and who we're holding. And we look at all that, and then especially out of the second district, which is the Albuquerque metro area, has its own, sort of children's court, children's judges. In other smaller areas in the state, sometimes it's the same judge. They just don't have the bandwidth to, sort of have a children's court like Bernalillo County does. And they sit on a committee. It's called the Deepen Committee, and I'd be happy to get you in touch with the folks who run that. And that's also led by state leadership, not us, but judicial. So Judge Marie Ward, who's the head children's court judge there, it helps lead that. And then Annie E. Casey. So that it's called the Deepen Initiative because we're focused on exactly that, the racial disparity, as well as kids who are getting deeper and deeper into the system instead of us helping stabilize and exit. That doesn't come with any TA. That doesn't come with any money. It's just TA because we're deemed a model site. So like LA County, all these folks come and well, before COVID, they did. And then we would present to them and say, this is how we do it. This is how we got everybody to the table. This is how we divert. This is what we're looking at. Last time I checked, I think there's about 130 kids in the state that are in long-term facilities. So kid prison, and that number could have gone down by now. That's, a huge decrease than if you even look at 5 to 10 years ago. I think when you're talking about the school to prison pipeline, there are individual policies, some of them, or individual interventions, I should say, like a school peace officer or a resource officer. Those have varying outputs or outcomes. Sometimes like a school resource officer, if they're trained well, can do some conflict mediation. Sometimes school resource officers will just make a referral to us The way New Mexico works is the referral comes to probation. If it's a misdemeanor, we figure out how to handle it. And like I said, in the children's code, it's like, I think it's the first 3 in a 2-year period get diverted. So we're going to divert those kids. We're going to try to meet their needs. And so then after the petition, if it's a felony, we have to send it up to the DA. But we have a staffing around the felonies and look at priors, look at other risk factors, look at alternatives that we've tried. And so the DA may press for probation, we may press for probation, but that would be the next step, would be formal probation. I think with regards to what I've seen, my son went to George Washington High School in Denver, and they had a restorative justice program. They were probably about, 90%, I hate the word minority because it depends what state you're in that works, but not white people's. And they created this restorative justice program that handled all conflict and all, kind of infractions internally and stopped the school to prison pipeline. They did absolutely amazing work. And I know that that's been replicated, and we do some restorative justice stuff with some providers around the state. But I think in answer to your question, what would be really great would be if people looked at restorative justice, not from the framework of an adult model where you're making the person who steals your car, I don't know what a good example is, buy you a new car. Not that. These are kids. Restorative justice is about, bringing a healing circle together, doing some truth telling, shifting the power and control back to the victim. And sometimes that's all that's needed when a kid does something bad to you. I mean, having them, of course, I made my own kid when he shot out someone's window with a BB gun, march around, and I stood there and he knocked on the door and he apologized. And he was like completely scared, and the neighbor wanted to give him $20. I was like, no, you can't give my kid $20 because he's got to apologize. But sometimes that's exactly, sort of what is called for in those situations. So, I mean, just the realness of sitting together and owning what we've done and what can we do to make it better.
If I could, I'd like to just add in one thing about that BHSD has been doing for some time about exactly this issue. We fund a project in elementary schools in particular called the PACS Good Behavior Game. And before I came here, I thought, okay, a game. It actually turns out to be an approach to recognizing children, recognizing the trauma in the children, and responding to their behaviors in a trauma responsive way. To help them learn how to manage the strong emotions that come with having lived through traumatic experiences. And one of the best experiences I've had as director of BHSD is I went to the Cesar Chavez School about 1 mile down the road from where I'm sitting with Secretary Grace, and we watched the PACS Good Behavior Game in that school and realized that's really the ideal implementation of it, because they very quickly determined this is not going to be as effective unless we change the entire school into being a trauma-informed and trauma-responsive environment where we recognize the children, we love the children overtly, and we support them in their struggles without pathologizing the behaviors that they bring. And so we actually went into a kindergarten classroom and during one of the PACS Good Behavior Game interventions, and I have to say the kindergartners behaved much better than the adults did in the room while we were there. The outcomes are very promising. I wish that we were measuring longer term outcomes at this point. What we see though so far is that children who get exposed to as little as 2 years of the PACS Good Behavior Game early in the elementary school are much more likely to be consistently attending school and be passing grades all the way through middle school is what the outcomes we have to date. But I suspect that much more, rather than the academic outcomes, much more important is going to be the ability to manage yourself when you're troubled, leading to the ability to realize your potential as you age. So I just wanted to mention that as well.
Awesome. Thank you guys. I really appreciate that. I guess the other things that I was kind of getting at with that question wasn't just sort of misdemeanors and felonies, but also suspensions, expulsions, disciplinary actions that sort of affect how somebody or somebody's ability to attend higher education, eligibility for scholarships, things along those lines. And I'll just say, I mean, when I was in high school, that seemed to be the case, is that, you know, if something happened and it was within your vicinity and you were a person of color, it was, hey, you. Yeah. So pretty frequently that would happen. I don't think that was a local phenomenon. And I'm curious and I was curious then, my parents were curious then, if there was any sort of state regulations on how sort of disciplinary actions were handed out in schools. So
I think that, Amy, are you going to have any sort of panel with public education? If not, I can ask about it and get back to the group, or I'll get back to Amy around it, because that to me would be, you know, some sort of training and then translating it into exactly what you're saying, some sort of policy. And I just don't know, besides my own kids going to public school and running into some problems here and there, not the same kind of problem. I just don't know. So Amy, would you like me to figure out, or are you going to have someone?
That's going to be handled in the education subcommittee, which will, of course, invite you all to. Our focus at this point is really around restraint and seclusion, but we can bring in much of what you're talking about as well, and that we've really been focusing it on our children with disabilities, or our children with disabilities who have not been tested to say that they are children with disabilities. But the education subcommittee will be handling or having that presentation, which we'll bring forward to the full council.
Okay, perfect. Thank you.
I'd just point out one other thing, and that's that very, very directly to your question, Hussein, is that an outgrowth of the understanding of adverse childhood experiences and how they impact people is that a few school districts around the country, starting with the Walla Walla School District in Washington State, determined to become trauma informed and trauma responsive, and it started in what was called what we call in New Mexico opportunity high school. So the kids that were kind of drummed out of the regular high schools because of what were perceived as behaviors were put into a particular high school in Walla Walla, and they had a graduation rate of, I don't remember the exact number, and I don't want to but it was in the 30% range, something like that. And when they became trauma informed, within 2 years, their graduation rate started skyrocketing. And there's actually a film about it, and I was trying to remember the title of it, and you might remember it, Bryce. I don't. That tells the story very eloquently, and their graduation rate actually went up into the high 80%. It's when it stopped being about what's wrong with you, kid, and started being what happened to you and how can I help you in this moment when you're struggling. And it's very impressive results, and I would hope we could move in that direction, but that belongs in the education field, not in mine. So,
thank you. Margaret, did you have any questions? Sorry, I didn't mean to cold call you.
It's like when I was teaching and I would cold call. No, Neal, what I wanted to talk a little bit about was whether, in addition to the class standards, which I did a good bit of cultural competence teaching, both in the law school when I was in the clinic, and then in the medical school, because I was part of the cultural competence faculty for several years. But more recently, we've been looking at what's called structural competence. And I just wondered if, and of course, as far as I know, there aren't yet standards, but I do think that the class standards were more focused on personal and interpersonal racism, and structural competence is more is upstream medicine. So it's looking at institutional and structural racism. And I just wondered if you or the people that you're working with are also beginning to refocus these competencies.
So thank you for that question, and it's a really good question. I think there's two quite different answers involved with it. I think in terms of awareness of the impact of structural conditions which shape behaviors and therefore shape health, and I want to rephrase what I just said about shaping behaviors, because the behaviors are also shaped by the potentials that are offered to the people who are living within those structures. So instead of, I'll give the example of obesity. Instead of blaming the poor for being obese, it's an understanding of, well, they have to have calories to survive, and they have to have calories to feed their children, and they're going to provide the calories that are available. And if the structure is such that they are in a desert for healthful foods, they're going to eat the foods which contribute to their developing those conditions. And so that awareness, I think, is growing, both in the behavioral health side and the physical health side. But I think the responses to it are not as clear to people. And I've actually run into administrators of clinics who are tired of talking about the social determinants, because they feel like what it does is it makes the healthcare system responsible for resolving all of society's ills instead of focusing on what they do well. And I lean more towards, well, it is part of healthcare to point out these structures that are inimical to well-being, whether physical or emotional well-being. And so that kind of prevention side is a critical part of what we do, at least in terms of raising our voice about this is not just a question of poverty separate from health. Poverty is a part of health. But I don't think the field is quite there at this point. Bryce, would you disagree about that?
No, I wouldn't. But I also think that part of that is that everybody comes together on equal footing and, tries to solve problems, not in silos, but, with that sense of innovation. And I'm also just thinking, Margaret, like hopefully this is going to be an output of this group, maybe not this group in particular, but your whole group, because this is what we need. When you started saying the structural piece, I started Googling it and I stopped myself because then I'll get distracted. But that's exactly, we need to take it to the next level. And so I'm super curious and interested in this.
Well, let me tell you, so I'm on the working group on early childhood education and the land grant permanent fund debt. And so one of the things that I was thinking about as I heard both of you speaking is that in the event that this amendment is successful over the next few years, I think the kinds of things that we want to definitely think about is including things like the PACS Good Behavior game, trauma-informed programs that really begin to change the models of education, right? From pre-birth, from prenatal care through kindergarten, right, the 0 to 5 years, and really begin thinking about behavioral health as really integral to early childhood education.
So
I would totally agree with that. Sorry, Neal, just one piece. I would totally 100% agree with that. And I was doing some reading over the weekend, and it was basically, let's stop thinking about behavioral health as a cost, and let's think about it as an investment, because truly moving forward, especially, you know, because of what the pandemic has exposed and some of the, you know, risks associated of being in isolation, not being with peer groups, all those things that, you know, our kids are currently, you know, sort of going through. I think that that's exactly where the conversation needs to be. And yeah.
Well, and that it should be called early childhood health, early childhood education, early childhood, you know, I mean, because that naming has so much in terms of, you know, how it structures our thinking, right? So thank you. That's very helpful. My father was a social worker, and so I come to behavioral health with an affinity, if you will. Thank you.
So this group had a few suggestions around behavioral health, and really just want to see if you all can give us some maybe your ideas about how we might be able to push that forward through statute or legislation, or even just in a recommendation to the governor of things that she might be able to suggest to others. One of those was the behavioral health councils in each county, something that I think was something during the Richardson administration, if I can remember. Can you talk to us a little bit about how that might be able to be moved forward as a suggestion?
Well, I'm glad that Jane is on as well as the policy advisor. And I don't know if she had to jump off on another call or not, but that's kind of what I was also talking about, Amy, at the beginning in the structure of the collaborative. We need this local level folks that, you know, communities pull together, understand, you know, what they need, and represent that to the state. State needs to provide data, which Dr. Scraggs did, by the way. There's something called the HSD data book, and it's available on the web, and you can go to your county and look at some county related data, but there has to be that feedback loop. And so what I would say, and just in my own view, and in this current role, would be aligning it with that current piece of legislation, or that the existing legislation around the behavioral health collaborative, not necessarily creating something separate, because there is already you know, a venue that exists and gets lifted up to succeed. If there's, you know, like the health councils, for example, there's health councils at the local level in a lot of places. As the behavioral health collaborative councils changed and shifted and kind of had to die because of lack of funding, as some of those folks shifted over to the health councils, that means if that's going to be the sustainable venue, that means, you know, repurposing, you know, their roles and responsibilities and adding behavioral health. Is that the way we need to go? I think we need to go to integration. I think we need to go to primary health and physical health and behavioral health care integration. So whatever makes the most sense, you know, my initial thought is, I agree with you that we need that. And my second thought is, how do we set it up to go well in an existing system that has, you know, some of that already written in.
And if I could, one of the joys of the position I'm in is getting to work so much with Bryce, because we think so similarly so often. It's really lovely to have. But and the reason I said that is because when she talked about integration is the way to go. A couple of things. One is, we know that when people have behavioral health problems, they're much more likely to go to a primary care provider before they ever get to a behavioral health care provider. So it would be of assistance to them and to society to have behavioral health care be available where they go, rather than saying, no, this is the wrong place, you have to go across town. I was actually on the board of the Primary Care Association while I was at HMS, and one of the things we estimated in New Mexico that about 60% of encounters in the federally qualified health clinics that were apparently physical healthcare encounters, about 60% of them were actually behavioral healthcare encounters. And so driving a kind of primary behavioral healthcare into those primary care settings is probably a good way to improve access and improve responsiveness to people's behavioral health problems. So I kind of have in two minds about setting up behavioral health councils in states when it might be it might take us further along the pathway if we require the health councils to include behavioral health in the work that they do. So that's just my perspective on it.
Thank you. That's a really great suggestion. One of the other suggestions that has been made by this subcommittee is requiring hospitals to have Suboxone treatment in them, or at least hospitals that get state funding. So what kind of advice do you have for all of us and how we might be able to move that forward is the suggestion? Is that statute? Is it a rule? How could we do that?
Well, I was celebrating the suggestion first, and the one thing I would add to it is to make sure that they are also incentivized to coordinate care beyond the emergency department, beyond the hospital, to the ongoing behavioral health providers in their community or nearby, so that they have a relationship, so that if someone gets started on Suboxone at a hospital, that it can continue in a seamless way as they leave. Because one of the things we see in the system right now is people might get started on it in the few EDs that do provide it around the state, and then it becomes a struggle and actually a danger point, transitioning them from that introduction to Suboxone to ongoing care, which includes the medication-assisted therapy, involves therapy as well as the prescription, not just the prescription, and it's more effective that way. So,
is there any existing requirement, Neal? I think that was the other part of the question in terms of providing medication-assisted treatment, for example, or having to treat folks with substance use disorder that come into your hospital.
Unfortunately, I don't believe there's a requirement for that. And one of the things we know from the research is that people who go into emergency departments with substance use disorders or serious mental illness are going to spend longer in the emergency department, on average across the system, across the United States, and get lower quality care than people who present without those problems. So it's both making it available, but also helping shift the culture towards we have the opportunity to help this person move out of the condition which brought them to the emergency department, and
he'll be right back
after this commercial break.
We did lose him. Amy, my dog has been misbehaving. Yours is always so quiet and calm in that photo, I can't imagine a regulatory mechanism to mandate this. I think this would, I just can't think of one where there'd be authority by anybody to require it. That you can incentivize in Medicaid, this is, I think that what Bryce, they couldn't see me, but I think all of us were laughing because we've all been on a call recently discussing how we can increase the emergency department's engagement in this and the hospitals doing this. So we welcome whatever ideas and recommendations you have.
From what I've heard from the providers here, it is really an issue of that outpatient coordination that takes a significant amount of time, because some people either don't have IDs or they have a type of insurance that isn't compatible with the Suboxone clinic or the health clinic they're trying to connect people to. And just figuring this out takes an enormous amount of time. You know, calling different places, finding out who takes what, who doesn't take what to do if someone doesn't have the appropriate insurance or the ID. And in an emergency department like UNM's, where when non-COVID times is just packed, you know, that's viewed as pretty valuable time. I don't think that's an adequate excuse. I think we certainly need more options in the community to send people for this, you know, this treatment that is the community standard, right? So before I move on, I was going to ask whether, you know, they do mandate other things for us to prescribe opiates, right? So I get out of school, I graduate, day one, I can write fentanyl, right? I can write a prescription for fentanyl. In order to write for Suboxone, I have to have my X waiver, which is, I mean, it's not difficult to get. It is pretty time consuming. I'm wondering if the same way they mandate that I have to take a certain amount of continuing medical education to prescribe narcotics, that maybe maybe making a lesser form of training to say that you can prescribe Suboxone, but making it a requirement for my license, right? Because that's through the state, right? That's not, no, it's through
RLD, isn't it?
No, the X waiver is a federal requirement, and there is a movement to eliminate it.
No, I mean the requirements for writing narcotics, like that they have that requirement for me through the Board of Pharmacy. So they require that I take, I think it's like 9 hours or something along those lines of continuing medication, continuing medical education on opiate prescription. And I'm wondering if there would be some legislative way of flipping that or including part of that in medication assisted treatment.
Yeah, I don't know if that also sort of derives from an FDA requirement. I'm not sure. There's an issue about keeping your prescriptive authority and what the FDA may require, but it's a really interesting question.
Coming back to what Amy was talking about, it would, I still would be interested in exploring if there is an administrative or legislative or what kind of way to ask hospitals that get funding from the state to follow a minimum standard of care around access to medication for opioid addiction. There are hospitals around the country who are easily starting people on Suboxone in the ER without any problems. And that actually helps folks not keep coming back to the emergency room, to contrast, Hussein, what you're hearing from folks. And LA County, I mean, they have a really rapid way of assessing, planning, and then they built a bridge clinic. But there are community providers. And if I work in the emergency room, which I do work on a rural reservation, work in the ER, whatever medicine I prescribe in the ER, I'm not responsible for how folks get it when they leave the emergency room. There should be a community network, but this is the only place where this keeps coming up about a community network when we're talking about what's on formulary and what's prescribed in the emergency room. I can start someone on antipsychotics and I'm not sitting there thinking there's not enough community providers. So many other hospitals around the country have implemented, whether it's even not in the emergency room if there's pushback from there, but among the hospital system, access to medication assisted treatment. And at UNM, which is our largest safety net hospital provider in the state, the ER is not doing anything to get folks on Suboxone. The county care campus, the MATS detox facility, has a lot of restrictions and they're not taking folks that many to start them on Suboxone. And then the only people who are routinely prescribing Suboxone or methadone are at UNM ASAP, the Addictions, Substance Abuse and Prevention program, in which if you look at the quarterly reports for UNM over the last year, the numbers of encounters for methadone and for Suboxone have drastically decreased. So where are those folks going? What is the Safety Nets Hospital responsibility to the community? No one in the Department of Psychiatry prescribes Suboxone. Family medicine department is trying to do it here or there, and they're training up all their residents. But then again, there's a question of who's actually doing it in practice. It's abysmal, like the role of the Safety Net Hospital in providing this critical service. So, one of the outgoing county commissioners from our county recently had said, it's been so frustrating to try to get UNM to have some responsibility on this, that maybe it makes sense to work through a legislative angle or some other kind of state mandate that hospitals across the state, and if you're getting state money, that you have some responsibility to your community to provide this really simple process for helping folks get on medication for this one thing, because you do all these other things. So from that angle, I can't remember, Jane, we talked to the Pew folks when they talked to us at Casa de Salud, and they were talking to stakeholders around the state, and I think they had said that there were other states that had done something similar to this, but I'm not recalling. And so I'm curious if there's an angle to take something legislatively about mandating that folks who get money from Medicaid, I mean, this would also apply to, most residential treatment centers do not allow for people to come in with medication assisted treatment. So they have to detox off of that, and they get money from Medicaid. And maybe I'm exaggerating by saying most. That was my sense a couple years ago. And in the community where I practice, there are a lot of residential treatment centers that get tons of money from Medicaid that don't have an obligation to provide standard of care treatment in their facilities. So this feels like something that would be really great to move legislatively or administratively, but that may be too naive. It just feels so important.
Yeah, and we actually just had a conversation with Pew about this topic, and I'm trying to remember. I know that that some of our federal grant is going to be used to try and work with hospitals that start to initiate this. And I can't remember, Neal and Bryce, kind of where we had left that. I think that's the grant that is overseen through BHSD, Neal, the SOARS grant, or
yeah, the SOAR grant, that's correct. And I was just looking for my notes from the Pew feedback, whether they recommended that. I believe they did, but I wanted to be sure about it, a legislative solution for that.
So I do come in with sort of the pragmatic look at this, but this group, I want to be careful. You should recommend what you want to recommend, and but I know enough about the hospital association that they will be all over this, and all of the rural hospitals who have members representing their districts, will. In the middle of COVID, they're going under, they're losing money, and now it's a mandate, which does require some investment, an investment of training, of support, it's not nothing, I guess, and so my recollection, I mean, we were talking, I think, about the carrot versus the stick, and thinking about using the carrot to find some partners that want to do this and do it well, who then can be sort of leaders within the hospital association and community to be doing this more. I really do appreciate, though, what you said about, you don't have to, you can still prescribe antipsychotics even if you haven't figured out all the wraparound and appropriate services and therapy that need to go with it. And that's important, because I do worry about people just prescribing without providing meaningful support to the individual. The other question I had and this is really more for the experts here, and that, we're seeing so much more polysubstance abuse and use, and that meth is on the rise and fentanyl on the streets on different things, and that how, and that's the efficacy of Suboxone when somebody is, it's not just opioids, but other things that they're consuming. And I thought there were some issues around that, and that was further complicating medication-assisted treatment these days, but I may be wrong about that.
No, I think you're exactly right about that. As we were working with Pew, one of the things we found was some emerging research showing that people who are provided Suboxone alone are more likely to be using methamphetamine a few months later than people who get Suboxone and therapy. So learning ways to deal with what led them to be using drugs in the first place, rather than because with the Suboxone, they're not going to get any of the benefit, so to speak, from using the opiates that they were looking for, but they'll find a different way to do it unless they learn the skills to avoid doing that. So there was some pretty robust evidence that that's one of the reasons you wanted to have the referral in addition to the medication was, and it looked like there was a relationship between the development of MAT or the prescribing without the therapy piece and increased use of methamphetamines.
And I also do think UNM is a unique institution. I mean, everybody gets state funding. They all are both Medicare and Medicaid. The Medicaid is our, link at the state. But UNM is a unique institution in the state and the leading safety net hospital in New Mexico. And so it's an interesting, I don't know, but maybe Pew did pull some of that together, Neal and Bryce. We can.
Angelique, do you know, is in terms of prescribing for MAT with the polysubstance, are there interactions, or I'm sorry, I don't know the right words, but that you'd be concerned, you wouldn't prescribe if somebody was using methamphetamine as well as opioids?
Oh gosh, no, you should be able to prescribe to help someone get off of opioids. Methamphetamine wouldn't necessarily interact with that. Benzodiazepines, sedatives, alcohol, other downers would be concerning. But I think, Neal, I understand what you're saying about the concern with just providing medication. My concern is that folks who don't have access to medication don't have access to therapy, and I mean the data is stunning around medication-assisted therapy. I mean, Suboxone helps reduce opioid overdose deaths by 50%. I don't know of another drug that is that life-saving in all of the medicines that I prescribe, and so it feels like it feels critical to get the medicine to people as soon as possible and then build the other things around that. And that's what we're doing locally. And those other pieces, I agree, need to be built. If they're not built, I mean, there's back-to-back studies of Suboxone and Suboxone plus therapy. There is not evidence that Suboxone plus therapy is more life-saving than Suboxone alone. At the same time, therapy is hugely important for building the coping skills and other things so that when someone's not on Suboxone, or so that they don't move to other drugs like meth, absolutely. My concern is in the state, there's critical shortage of low barrier access to medication. Methadone comes with a whole lot of requirements, but is great, but there's a limit of where you can get methadone in the state. Suboxone has a lot of other barriers, and we right now in the country are seeing a huge rise in opioid overdose deaths in the middle of this pandemic. And I don't know what the data is around what that looks like in New Mexico. We run a syringe exchange out of our clinic, and numbers have skyrocketed in terms of people coming in to get new syringes and folks getting into treatment and otherwise, but there is not enough low barrier care, and that's a problem. And that ties into something else that I was curious about with BHSD. I mean, I just see I'm excited to learn more about BHSD's involvement with substance use and treatment, and I think there's so much critical opportunity. A few years ago, I heard about there's a program that Optum had to be able to support the cost of care for medication-assisted treatment for uninsured patients. And it felt so backwards in that it was only for psychiatrists in the 2000s. It was only for psychiatrists who uninsured people can't even go see because most of them are charging outside of, are charging a high price. And there needs to be some kind of system for people who don't have insurance, which I think, I might be wrong, is about 11% of New Mexicans. So 1 out of every 10 people doesn't have health insurance and therefore doesn't have access to medication treatment. And then even in terms of general behavioral health in our adult population, I'm curious also about what BHSD is thinking or doing around uninsured people and therapy outside of addictions, because where I work, 70% of our patients are uninsured, and it's really hard getting them therapy. We're building that into our own organization because it's so hard to get it elsewhere. And it feels like an important need for the state to find a way, obviously hard to say during the COVID pandemic when budgets are being slashed, but our uninsured patients would have to pay, $80 to $150 a pop to get therapy on the private market. So there are these kind of conflicting things around addictions and then around behavioral health in general for the uninsured adult population. And then I'm curious also about BHSD's involvement is there involvement, and I've seen some of the presentations with corrections recently, how do we help people who are slipping up on their parole or probation with polysubstance use or with relapses or whatever, not go back to jail and then have that be their behavioral health facility. So there's a lot of questions in there and a lot of things, but excitement also about what's possible in this state. And given we're on the Governor's Council for Racial Justice, we're excited also about hearing what you all think would be helpful to push in this time when clearly the governor wants to put energy on this, and we can make statements as well as policy recommendations and legislative recommendations. And I know that there's some legislators who are interested in bringing some things to legislation. And obviously, Jane, from what you said, things that are practical. It doesn't make sense to bring things that can't get passed for sure.
Yeah, but the governor takes on things. So that's why I'm saying, I'm giving you my assessment, but yeah, and I definitely think an across the board mandate for all hospitals in New Mexico, to provide Suboxone in their emergency departments, for example, or I think that's going to be that would be pretty tough. And the hospital association has got, they're around the roundhouse a lot, and they've got.
Yeah, the idea wasn't necessarily around emergency departments. It was around hospital systems doing in their system of care. Yeah. So
what next at our next meeting, I know the Medicaid leadership is coming, and why don't you, if you can remember to ask about what can be kind of incentivized through the MCOs. That's our best tool through those MCO contracts.
If I could, I'd respond to one of your questions, and that's that BHSD has for a long time used a significant part of our state general funds to subsidize treatment of all kinds in the behavioral health side for people who don't have insurance. So one of the things that we've been doing since I got there is we've been moving providers who were not Medicaid providers because they knew they could access that fund and not deal with the rigmarole of being a Medicaid provider, of requiring them to go to Medicaid for the things that Medicaid covers, thus freeing up more of the state general funds for the people who don't qualify for Medicaid and for those services. So that's a pretty significant part of our spend, and that goes largely to the community mental health clinics that are part of that safety net, and to the federally qualified health clinics that are the other side of the safety net. So those are the main utilizers of that funding.
Did you want to know more about the initiatives that BHSD has been doing with some of the county detention facilities in behavioral health? I know that those questions had come up before, and I think Neal's probably best to talk about that.
That would be great.
Yeah, I'd asked specifically around the RISE program as well as LEAD. My wife is a public defender here, so she has some experience with the LEAD program, and I had some feedback when we talk about it, if that's okay.
Sure. So let me start with the RISE program. It's actually the same program as last year. It was called the Intervention Demonstration Project because we received funding for 1 year, and we funded 4 counties to develop programs to facilitate continuity of care for people in county jails in those 4 counties into ongoing care as they exited the jail. And that was largely focused, not exclusively, on MAT, and then it had local variability. Different counties developed it in different ways. So a lot of them also included housing as a way of trying to stabilize people as they move out of that transition out of jail and back into the community to provide the kind of supports that maximize their opportunity to take advantage of the therapeutic continuity of care. So it was care coordination, medication-assisted treatment, facilitated referrals, that kind of stuff. And because the first year it was looking very positive, this last year the legislature provided more funding, and so we've been able to expand it to 8 counties at this point. 1 stepped out. It was 9 for a moment, but 1 stepped off because of some local difficulties with developing MAT, frankly, some public resistance to that. And the outcomes are quite interesting. We've provided an awful lot of training as part of the RISE funding to jail staff, and training on trauma-informed and trauma-responsive care, because it turns out that had a lot to do with the quality of the care they were receiving in the jails. And the quality of the care they were receiving in the jails was predictive of the ability to take advantage of facilitated referrals after they got out of jails. As part of that, we also have focused on making sure that Medicaid eligible individuals, when they're in jails, quickly become eligible for Medicaid again. And so we expanded the number of people who could do presumptive eligibility for Medicaid so that we would reduce that drop off, because that was a critical drop off, especially for people on medication assisted treatment. If they came out and found a gap where they were not eligible to see providers, they were more likely to relapse than if we could close that gap. So that's been pretty successful as well. Again, there's variability between the programs because we let for a lot of local design according to what they were doing in those counties. And not all the counties that we offered it to were interested in having it. And that's a separate discussion, I think, at some levels. But we have ongoing funding that we can continue at least for another year with those 8 counties. And then as far as LEAD goes, we did get legislatively directed dollars to expand LEAD access in a number of counties. And again, I think there's some cultural work, background work to do to try to facilitate the success of the LEAD programs. Frankly, I'm personally a little more excited about the 988 initiative, which is coming down the pike federally, than I am by continuing to ask law enforcement, which is very good at what they do, to also be involved with the healthcare system and responding to social determinants. So the 988 system is designed to try to redirect dollars from law enforcement to community healthcare responses to mental health and substance use crises. So I could talk more about that if it's not common knowledge from the people already on the call.
I think that would be good. I'm unfamiliar with the 988 initiative.
I'll just give you a real quick, 10,000-foot overview of it. And 988, the reason we call it 988 is because it would replace 911 you would no longer dial 911 for a mental health or substance use emergency. You would dial 988. And technologically, that part of the system is well developed, and including in New Mexico, we should be pretty seamless. That 988 number is supposed to go live July 1st of 2022. And we already have the infrastructure where the calls would go to the New Mexico Crisis and Access Line, actually, would be the facilitator for that in the state. And then they would be kind of the air traffic controller to connect those people in those crises to crisis response teams, which we are not well developed with yet. But those would not be teams that would involve police departments unless there was a concern about violence. And in most cases, for behavioral health and substance use crisis, there is not a concern about violence. So the vast majority would be social workers, for example, and peer support specialists going out to people who are in crisis. And then the third aspect of the 988 system is building out crisis triage centers, which we have a couple up and running in the state. And we're very anxious to build out more of them, because the basic concept of 988 is you have someone to call, someone to talk to if you're in crisis. If you need it, there's someone to come to you. And then if you need it, there's a place for you to go, which is specialized for behavioral health. And that would help relieve the pressure on emergency departments and increase the access to appropriate care for people well prepared for responding to those crises. And freeing up the emergency departments to do what they're best at, and freeing up the police department to do what it's best at by redirecting some of the funding to that emergency response system within the behavioral health system. And that's a national movement that's going forward, a national project going forward. So that's why I'm excited about that process. And in New Mexico, I think we're in good shape in terms of the first and third aspect. We can build out the crisis triage system, although it'll be a challenge in some of our frontier areas, getting enough of them up. You need to be within about an hour and a half of people for it to be effective. And the middle piece about someone to go to you is also a unique challenge for a frontier state like us. I've been working with several other states which have significant frontier areas to try to learn from them about how they're trying to build out that part of the system as well.
Does that mean that the triage sites around the state will be funded by or supported by the state BHST? It's super exciting that this is happening.
My hope is it'll be funded by Medicaid.
Yeah. Okay.
Because about a tenth of the dollars spent on behavioral health in the state are state general funds that we manage through BHSD, and the other 90% come through Medicaid for the publicly funded behavioral health care system. So that's the bear that we want to make sure gets protected, because it's the one that determines how the system works.
Absolutely. And but is it like an imperative or a push from BHSD to have these crisis triage centers around the state?
Yes, absolutely. Yeah.
That's cool.
I think I want to hear what Hussein's wife thinks about LEAD. But before that, I would just add about the children's response. So I 100% agree with Neal that utilizing our new NMCAL, New Mexico Crisis and Access, is where it's at. We, in the CYFD world that I just left, but I'm still getting to work with, we got a federal SAMHSA System of Care grant. You may have heard of those, which is really just about rebuilding, like I said in the beginning, community-based systems of care. We're working with NMCAL to develop a mobile response. We can only really do it in the beginning in our two grant counties. But to try on, they're not calling it in the children's world mobile crisis. They're calling it mobile response. And the states that have seen giant success with diverting kids from getting involved with juvenile justice system, for keeping kids out of emergency rooms and acute care and residential treatment, have deployed these mobile response teams. And it's usually a peer, a mom or a dad with lived experience that knows how to handle a kid in a crisis. And some states have said, okay, if you're in child welfare, you automatically get a team, and that team will be your first response. You have problems with this new foster kid that's in your home. Here's the number to call. This team comes out, gets to know you, and all of this happens to stabilize the child instead of going through child welfare where the knee-jerk reaction is to remove the child. And so just to close out on that, for kids and families, the number one success piece is that we allow them to define their crisis. If a mom calls in and says, my kids chased me around the kitchen with a knife, anyone's going to say that's a crisis. If a mom calls in and say, my daughter won't come out of her room, and she hasn't come out of her room and whatever, then some folks at a triage level would say, that's not a crisis. So I think it's just really important to remember that parents know exactly what's going to escalate into a crisis, and effective responses is putting them a little bit more in the driver's seat. But now I'm interested in the lead feedback.
Absolutely. Thank you for letting us know that as well. A couple things before I jump into that. I think the crisis response centers, so that's fantastic. I know that I have friends that practice in Minnesota, and they say that that's available there, where they have like these drop-in crisis centers. She knows that there's been that she really likes them, that her patients have really benefited from. So I think that's a fantastic idea. Not to put my wife on the spot, and I'm hoping I'm explaining this correctly, that if there's an encounter with an officer, there's going to be some files, some charges filed. Instead of going through court, they have them and go through this diversion program. But the charges at the end, once they complete the diversion program, the charges are dropped, as opposed to them just never being filed. That's one of them, because you can still look up that you were sort of charged with this, and then it'll say what the resolution was. So that was my impression of that discussion, was one. And then two, she feels that for this being sort of a healing process, a medical process, that that law enforcement being involved all the way through is sort of a conflict, and it makes it difficult for the person to to be frank, or to be involved in the therapy part of it. So I'm hoping I'm voicing what she's saying, and it makes sense to me that if this is truly a diversion program, and the purpose is behavioral health, then maybe it should be like a warm handoff, as opposed to the officer being involved throughout the whole process. So just those two things.
Neal may have had to jump on a call, but I'll definitely relay those back to him. I think that it's a work in progress. I think that that's not the second criticism is not new. I've never heard of the not criticism, but feedback. Never heard of the, instead of the charges being dropped, never having been filed, which makes a lot of sense in some ways. If it's true diversion, I hear what you're saying, but so I don't know, Jane, if you wanted to respond to any of that, if you want a response, Hussein, or if Neal's back on.
I thought that would be something that would maybe enrich the program, because I'm all for diversion, especially situations like that. Right.
Well, so the one thing I would add, and I was listening, is that some of the RISE programs have been implementing I forgot the title of it now. It's a sequential intercept model. And the whole idea about the sequential intercept model is to try to divert people before they get to jail, to identify these critical moments in their life. Those are the intercept stops, where we can get people away from the criminal justice system and into treatment instead, as a way of not getting to the point of having any charges to file is the basic idea of it.
Yeah.
Actually, Neal, can you, oh, I'm sorry, Margaret, go ahead.
No, go ahead, Joy.
Justice Nakamura created something called the Z team because she learned about the sequential intercept model and created a committee that includes the Association of Counties, BHSD, and a number of judges around the state to address the behavioral health needs of those involved in the justice system, both on the civil and criminal side, I think, but not juvenile justice. That was Justice Vigil, Barbara Vigil, who has been leading that. Neal, do you want to just briefly describe it, just in case this group is interested in learning more about it? I haven't attended those in a while.
So yeah, I think that we lost a little bit of steam, and I say we because I had the honor of being invited to participate in it. And the reason it was called the Z team is because it was named after the zero intercept, where you capture people before there's any involvement of the justice system. You recognize accumulating difficulties in their life, and Justice Nakamura's idea, which I think was brilliant, was if we can pay attention to the early indicators in life, including the ACE score of children and of families, then and direct services, focused opportunities for meaningful connection into the broader society, then we can reduce the number of people who ever get involved to those first intercepts when you're first suspended from school, for example, or other moments like that. So it was actually the last in-person presentation I got to make was to judges before the COVID crisis came for the
Yeah,
Z.
she was mandating some continuing education for judges around behavioral health issues. And so I just wanted you to know that that's another piece of what's been happening.
I'll also point out that there are a couple of judges around the state that have been making use of certified peer support specialists in their the courtroom to have an actual connection to someone who can help facilitate people moving out of that trajectory towards more involvement with criminal justice and towards involvement with meaningful treatment and connection, human connection.
And for folks on this call to awareness, there is some peacemaking programs at the tribal court level that address some of these issues in culturally responsive ways. I think Isleta Pueblo has a really good one. The last law firm I worked for, we did this entire peacemaking program, but it's for tribes to codify their peacemaking traditional ways instead of utilizing the state ways that don't understand the traditional practices. So you might get somebody, you get like healing circle and you bring everybody to the table and you can discuss as a holistic, how are you a part of this community and how are you going to maintain your relationship with the community? So that's something that Cheryl Fairbanks at UNM works really directly on with the Native American Rights Fund, and it's a good model to use. And that program did attend the Restorative Justice Conference last year. So it's very similar, but it just has the traditional component that can be built in with the tribe's perspective and their traditional components. So just for your awareness, peacemaking is what it's called.
So what I wanted to comment on was from the perspective of systemic racism, since we are a racial justice council, that I would hope that these initiatives have dimensions of a monitoring for systemic racism, which means, that you have to be really careful about the way that you develop your statistics, for example. And I think that, Neal, the model that is used by UNM it's very confusing. Just to give you one example, because they conflate Latinx people with white people. And so just in looking at those statistics, it says that there are 82% white, but there are 48% Latinx. There's no way of being able to disaggregate those and try and figure out, who is what, especially where the Latinx community is the plurality in New Mexico, right? I mean, we're talking about significant numbers of people, but it isn't only about data. it's also about training programs that need to be racially inflected, that need to be racially literate, frankly. And because I've been doing so much training around this and really developed racial literacy models for training, both in medicine and in law, I mean, there are very few people who actually have these skills and who would even know, how to go about assessing whether a program had these dimensions, to say nothing of really looking at the historic forces that are really where the structural racism is. I just think it's a very high bar to cross. And yet I think that if we're going to be dealing, I mean, I thought it was interesting, Bryce, when you talked about a woman calling in that her daughter doesn't come out of her room. Well, if it's a Latina mom, I want to know is she being bullied? Is she being bullied because she's Latina? Is she being bullied? I mean, suddenly the complexity of it is not having a crisis responder, but having a team of responders who are really able to think through what are the racially inflected problems. And it's just because I think that's the work that we're charged to do in this council, that I think it's important that we have this conversation. And that as initiatives become, are introduced, that everyone is alerted to the difficulty of making them different, because if we continue doing the things the same way that we've been doing them, we're never going to get at the racism problem. So I know that that's my soapbox, but
it's a great soapbox. And I think, as things are emerging, what's sort of coming out in front is, I hate the word consumer, but people that the system serves, being at the table and creating programs, policies. I mean, this is taking it a different level. And it's,
Bryce, when we talk about stakeholders, usually we are not thinking about South Valley moms, right? That they need to be at the table. We are not thinking about Isleta moms, right? We're not thinking about, to say nothing of African-American moms, just because, I mean, they're already so stretched and so few, right? And I'm saying moms just because I think they are health deciders. They are, they make a lot of the decisions, at least in the stressed families that I'm aware of, right? And I think that there is a especially valuable group to have at the table. But I don't think that when we think about engaging the community, that we're thinking about low-income, vulnerable people who are unvoiced and unheard in the conversation.
I think I'm learning a lot in these last few moments, and I just want to keep that piece of the conversation going, because I want to know more what that would look like. I mean, because you're talking, not tearing down necessarily the system that exists, although legislation could shift some of it, but you're talking about currently what's the best way to infiltrate systemic racism is by bringing in people that share power at a certain level to look at the organizational structure, look at the practice, look at the impact of services. And then we're also talking about diverse groups of people in New Mexico. And I love this idea. And so I just would ask Amy that if you guys go further with the structural class standard kind of approach to changing systems, I'd love to understand more and be a part of that.
Well, I think an important dimension of it is storytelling, that what we know about how you begin the process is by listening to people's stories and then being able to interpret those stories and turn them into into different kinds of solutions and remedies and resources, right? But it begins with stories.
Is there a way, while we
Thank
still
you,
have
Margaret.
Bryce and Neal here, is there a way in which any existing program or initiative could model this, where we could try to pilot on how to do it and to do it well? Rather than say we need to be doing this everywhere. I mean, Margaret, I don't know if you have thoughts on that, or Bryce may say we're doing that already somewhere, but.
Margaret?
I mean, I'd be happy to talk with Bryce and Neal. I mean, I'd be happy to talk about our model. I mean, this is a model that we've used primarily in reproductive justice, but the model is not about reproductive justice. It's about, I mean, we've used it I mean, we're using it right now at Boston University with the law faculty. Right. We've used it in a variety of contexts. It is not discipline specific. It's a set of skills about race, right?
Yeah, I don't think we are doing it anywhere, Jane. It doesn't feel familiar. It doesn't, it's kind of opening some different thinking for me. And so again, I do appreciate that on my personal level. But the thing that comes to mind when you say, is there a place we could do it? I automatically thought of our crisis line in MCAL. I automatically thought of, like, because we brought some things to them recently to utilize the NM Connect app, and we asked them to create focus groups. And so they're starting to do that. But my questions are, and not in a weird accusatory way, but like, how are your counselors, sort of trained? The linguistic piece we already track, it needs to increase. But with I don't know what the questions will be and how this would work. But if there's a potential there to start with the front door of the system, which is the crisis and access line, especially, as we're trying to get more users. Again, bad word, consumer word, but trying to get more folks as the suicide and depression escalates, or potentially escalates in New Mexico, but we're missing it. And we don't know what it is, but we're missing engagement from groups of people. And so with the outcome being that we have, the ability to really understand as this front door, this gate door that brings at, potentially vulnerable people that have never been involved in the behavioral health or any of our systems. How do we do that in a way that is shaped by what you all are talking about?
And if I could, Margaret, I just wanted to thank you for bringing up the issues that you did, and give you an example of one of the things we learned within HSD just in the last few months. We put together a project of asking users of the various HSD services what their impression was of HSD, and what we're doing badly, and what we could do more of, or what we could do better. And some of us advocated to have at least one of those sessions. There were 4 sessions, I think, that we conducted, and at least one be done only in Spanish.
Right.
And it was amazing to many people within HSD that the Spanish one was by far the one with the most participation from the public. And it had those voices that you're talking about, largely because Somos un Pueblo Unido decided to take advantage of it, to let us know what it was like to interact with HSD and be an undocumented immigrant, or be an undocumented immigrant in a mixed family with U.S. citizens, and to interact with HSD. And those of us who advocated for having a Spanish one, we weren't surprised that was by far the liveliest of the 4 sessions. But that's one tiny example, and I think we could do so much more about eliciting and really listening to the people whose voices don't get into these conversations nearly enough. So thank you for bringing that.
I really like that in how we do business with, the public and serve New Mexicans. I mean, rather than just providers you're funding and they should do it differently, what are we doing? And it's very intriguing. I like it.
I think that's one of the brilliant things about the Kevin S. settlement, and we won't go into that today because of time, but it requires CYFD and BHSD to get training and coaching and to have a validity check of being trauma responsive as an essential first step to developing a trauma responsive system of care. And I think that's just a brilliant conceptualization of, because unless we get it, we can't require it of other folk.
Thank you.
So we are at the end of our time today. Neal and Bryce, thank you so much for coming. It is so great to hear all of the amazing things that are happening within BHSD and within the Behavioral Health Collaborative. And Bryce, you know, I think for the last few weeks, everybody has been saying how great it is that you are now over there as the CEO. And I just want to co-sign on that everyone is saying. Really excited about you being there. Even though we lost you at CYFC, that was painful. It's great to have you running the Behavioral Health Collaborative. And so we know we will again see you, Dr. Bowen, when you come with Medicaid at our next time. But, you know, we hope that we can still reach out to you and ask some questions. I see that we have a few questions in our chat that might be some data. If we can ask you to respond to those, I'll send them by email. And yeah, we'll just keep the conversation going and hope that we are a council that goes on long term and can support you for the long haul.
Thank you all so very much.
Thank you, everyone.
Thank you.
Bye.
This is
Thank you for coming.
fantastic. Thanks.
Can I
Bye.
say a couple of things before we, just kidding.
Oh,
No,
I'll
I'm just gonna,
listen to you, Hussein.
I can say that.
I'm still on.